For next 15 to 20 minutes, we will try to explore airway anesthesia. Before planning for airway anesthesia, we need to answer a few important questions. And these questions are, do we really need awake tracheal intubation for the patient in hand? If yes, then whether oral or nasal intubation is required. Decision of oral or nasal intubation will help us to choose the airway anesthesia. Next two questions are whether we need sedation and choice of method of intubation. These all are important questions, and we will visit this slide again at the end of this presentation. Does this patient need awake tracheal intubation? This is the first and most important question to be answered before deciding about airway anesthesia. Let's take a practical example. This is a 50 years male posted for commando surgery. He underwent wide excision of oral malignancy 2 years back and also received radiation for the same. His neck extension is restricted and mouth opening is 0. Do you think this patient needs awake tracheal intubation? As per the difficult airway guidelines, we can decide about need of awake tracheal intubation by answering few questions. The first question is whether patient is having difficult airway. Second question is whether a supraglottic airway is inappropriate in your patient. If answer to these two questions is yes, then probably we need awake tracheal intubation. The next important question is whether the condition of airway is so bad that the airway is best managed via a tracheostomy carried out under local anesthesia. If answer to this question is no, then we should proceed for awake tracheal intubation. In our patient, airway is difficult and supraglottic airway is inappropriate because of 0 mouth opening. Answer to third question is no. Therefore, we conclude that this particular patient needs awake tracheal intubation. After deciding about the need of awake tracheal intubation, we will decide about route of intubation, either oral or nasal. These are two important factors which will help to choose the route of intubation, and those are, number one is mouth opening and the surgical access. In our patient, mouth opening is 0 and surgical access is oral, therefore we will choose nasal route for intubation. In case of cervical spine or thyroid surgery, with adequate mouth opening, we can choose to do awake oral intubation instead of nasal intubation. Airway anesthesia depends on your skill, available resources, and patient's condition. For cases in which topical anesthesia is not desired or proven to be ineffective, nerve blocks can be used. Needle blocks are at least relatively contraindicated in patients with coagulopathies or in those patients who are on anticoagulation. In our patient with 0 mouth opening, we will use mixed approach of topical plus nerve blocks for airway anesthesia. Always remember potential complications of nerve blocks include bleeding, nerve injury, and seizures from intravascular injection. Sequence of choice of method of intubation will vary from institution to institution, and we will also vary depending on available resources and skill of the anesthesiologist. At our institute, we use blind nasal as the first choice because my colleagues are very expert in that. Second and third choice will interchange depending on mouth opening. For 0 mouth opening, obvious choice is fiber optic bronchoscope, and for adequate mouth opening, one can use either video laryngoscope or even conventional direct laryngoscopy. Although sedation using drugs such as midazolam, fentanyl, propofol, remifentanil, and dexmedetomidine are undoubtedly useful adjuncts to perform an awake intubation, the secret recipe is undoubtedly in obtaining complete anesthesia to the airway structures. With good airway anesthesia, minimal or even no sedation at all can be used, and patient cooperation is much easier to achieve. If you decide to use sedation, remember not to give initial bolus doses of sedation for fear of losing airway and rapid desaturation. Coming to airway innervation, we all know that airway we intend to anesthetize is supplied by trigeminal nerve, glossopharyngeal nerve, and branches of vagus nerve. Internal branch of superior laryngeal nerve supplies area of the larynx above the vocal cords, and recurrent laryngeal nerve supplies below the vocal cords. Glossopharyngeal nerve supplies vallecula, base of tongue. To abolish gag reflex, we need to block glossopharyngeal nerve. Coming to the proper topic of airway anesthesia, we will first see topical anesthesia for blocking nasal cavity. We can use either cotton pledgets or inhalation technique for anesthetizing nasal cavity. 3 wide cotton pledgets soaked in local anesthetic solution are applied along the 3 walls of the cavity. 1 pledget is placed along the inferior turbinate extending to the posterior pharyngeal wall. The second one is placed along the middle turbinate in cephalad angulation to block the pterygopalatine ganglion under sphenoid bone. The third pledget is placed along the superior turbinate close to the cribriform plate and posterior nasopharyngeal wall. This blocks the anterior ethmoidal nerves. The above procedure should be performed bilaterally to have a bilateral block. The pledgets are left in place for at least 5 to 15 minutes. Please remember that this procedure is unpleasant and for patient, and we need to do it gently. Inhalation of aerosolized local anesthetic like a 4% lignocaine can be added to the standard nebulizer or atomizer and kept on the patient's face. The patient is asked to breathe deeply for about 15 to 30 minutes. Advantages of these techniques are that it is very simple and easy to perform. It is the least invasive, and if performed properly, it can anesthetize the upper airway to the trachea. Knowledge of the anatomy of the airway is also not needed. It can be easily, spatially useful in patients in whom blocks are contraindicated or not feasible. The plasma level of local anesthetics are also not very high. The disadvantage of this technique is that the block may be uneven and less dense and may occasionally cause CNS depression. Additionally, the technique requires the patient to inhale deeply, which may not be possible for all patients. This MAD, that is intranasal mucosal atomization device, it has a soft conical plug on the tip which forms a seal with the nostril preventing expulsion of the fluid. The spray atomizes drugs into fine mist of particles 30 to 60 microns in size. It is disposable and very cheap device for nasal topical anesthesia. Now coming to the topical anesthesia for blocking mouth and oropharynx, lignocaine gel 2 to 5% can be applied to the posterior third of the tongue. The second approach is using lignocaine spray 10%, which can be sprayed on the posterior third of the tongue and posterior pharyngeal wall after depressing the tongue with tongue depressor. Cetacan spray, which is a pressurized solution containing a mixture of 14% benzocaine and 2% tetracaine, can be used to spray the posterior third of the tongue and posterior pharyngeal wall. We can also use viscous lignocaine 2% around 2 to 4 ml and ask patient to gargle it for around 30 seconds to 1 minute. Lignocaine 4% 4 ml can be nebulized. Alternatively, a 10 ml syringe with 4% lignocaine can be sprayed through a small bored needle. We have to take caution. The toxic doses of local anesthetic drugs should not exceed while using large quantities for anesthetizing mouth and oropharynx. These sprays are freely available and very easy to use. Coming to the nerve blocks for airway anesthesia, glossopharyngeal nerve numbs the oropharynx by anesthetizing the glossopharyngeal nerve, which is a mixed nerve that provides sensation to the posterior third of the tongue, the vallecula, the anterior surface of the epiglottis, the tonsils, and the pharyngeal wall. Although the block facilitates intubation by blocking the gag reflex, we should remember that it is not adequate as a solo technique. For intraoral approach of glossopharyngeal nerve block, patient lies in supine position. The mouth of the patient is opened wide. The posterior pillar of the tonsillar fossa is identified after displacing the tongue to the opposite side with a tongue depressor. We can use a 25 gauge spinal needle or a 26 gauge 1.5 inch needle and inserted into the fold near the base of the tongue and advance slightly. A syringe is attached and aspiration is done. If air is aspirated, the needle is advanced very further. If the blood is aspirated, the needle is redirected more medially. 2 ml of 1%, not 2%. That is, we have to inject 2 ml of 1% lignocaine in the caudal portion of the posterior pillar. For peristyloid approach of glossopharyngeal nerve block, patient is positioned supine. A line is drawn between the angle of mandible and mastoid process. Styloid process is felt on the line just behind the angle of mandible. After preparing the skin with betadine, a 22 gauge short bevel needle is inserted at this point and advanced medially. Once the bone is contacted, that is styloid process, the needle is withdrawn slightly, directed slightly posterior, and after negative aspiration, we can inject 5 to 7 ml of 1% lignocaine. Superior laryngeal nerve block numbs the larynx above the vocal cords. The internal branch of the superior laryngeal nerve originates lateral to the greater cornea of the hyoid bone and passes approximately 2 to 4 millimeter inferior to the greater cornea of the hyoid bone, where it pierces the thyroid hyoid membrane to innervate the tongue base, the posterior surface of the epiglottis, the aryepiglottic folds, and the arytenoids. This block is also not adequate as a solo technique for airway anesthesia. The patient position is supine with neck extended. The greater cornea of the hyoid bone is palpated. This is identified just below the angle of the mandible and by tracing upwards from the posterolateral surface of the thyroid cartilage. The hyoid bone is held between the index and the thumb fingers of the operator, and firm pressure is applied to displace toward the site to be blocked. A 25 gauge needle is inserted to contact the greater cornea of the hyoid. The needle is then walked below the bone. A needle is advanced 2 to 3 millimeter to enter the thyroid membrane. In this position, the needle lies just outside the laryngeal mucosa. After negative aspiration, for air and blood, 2 to 3 ml of 1% lignocaine we can inject. Presence of air indicates that needle has entered the larynx and the needle should be withdrawn, while the presence of blood indicates entry into the superior laryngeal vessels. This block can be performed bilaterally. This is a small video. This video shows the superior laryngeal nerve block. Hyoid bone is displaced towards the side to be blocked, and after contacting the hyoid bone, needle is directed caudally. Negative aspiration and careful injection to avoid the intravascular injection is very important because we are very close to the carotid and the superior laryngeal arteries. If we want to avoid injection blocks for superior laryngeal nerve, then we can use inhalation of aerosolized local anesthetic, or after topicalization of tongue, patient is asked to protrude the tongue, which is grasped with the piece of gauze. Plages soaked in 4% lignocaine are inserted bilaterally using a pair of right-angled forceps into the pyriform fossa and left there for 5 to 15 minutes. Recurrent laryngeal nerve block. Now this supplies all the intrinsic muscles of the larynx except the cricothyroid. Direct blockage, especially bilaterally, is contraindicated because this could lead to complete obstruction of the airway. The patient is placed supine with neck extended for recurrent laryngeal nerve block via the transtracheal injection. In the midline, the thyroid prominence, the cricoid cartilage below it are identified. The cricothyroid membrane can be felt in the midline between these two structures. After sterile preparation of the skin overlying the membrane and the skin filtration with local anesthetic, we can use a 20 gauge intravenous cannula, that is the angiocath we can use. That is inserted through the membrane until we feel the loss of resistance, then the needle has entered the larynx. The needle is removed, the cannula is left in place, and a 5 ml syringe with 4 ml of 1% lignocaine is attached. Aspiration is done. confirm air is aspirated and then inject the local anesthetic. During injection, the patient might cough. Care should be taken to avoid the mucosal injury during this time. This was about the airway anesthesia with either topical or nerve blocks. And in many cases, we can implement combination of these two techniques. But adequate airway anesthesia alone will not guarantee a successful awake tracheal intubation. For that, we need to do careful preparation, review the clinical issues, check the equipments, explain your plan to the patient as well as your team members, apply patient monitors, apply oxygen via nasal cannula, check the anchor suction as well as the bronchoscope suction systems, check the patient's IV line, possibly administer glycopyrrolate, and if required, you can give adequate sedation. For nasal decongestion, for preventing nasal bleeding, because nasal bleeding will obscure the glottic view, we have to use some nasal decongestants, and these are 2% lignocaine adrenaline, phenylephrine spray, or the xylometazoline spray. While we are focused to achieve the excellent airway anesthesia through topical or nerve block techniques, we should remember that the safe local anesthetic doses. We don't want local anesthetic toxicity leading to convulsions or cardiac arrest in a patient who is already having a difficult airway. It will be a very daunting task to manage such a patient. It is better to avoid local anesthetic toxicity than to prevent it in a patient with difficult airway. If at all you land up in such situation, be aware of the local anesthetic systemic toxicity algorithm. Do not compromise patient safety. Before I end my presentation, these are last 2 to 3 slides. We will see 2 practical cases. This patient having adequate mouth opening, you can see his mouth opening is adequate, and you can guess the surgery. This is a big lesion, so he is probably posted for commando surgery. Anyone can answer, particularly residents, with whether you will use awake tracheal intubation or you will give GA to this patient. He was very anxious and his heart rate was 170. He was so afraid, even with such an advanced malignancy, he was trying to avoid the doctor's visit. So you can consider how much anxious he was. Intubation was not difficult, but ventilation was definitely difficult. I induced him with and was able to ventilate with the help of my colleague, and then intubated him nasally with North Pole endotracheal tube. Now, what is your opinion for this case with large thyroid mass? You can see these are the large thyroid masses. Can anyone guess or comment? Does this patient requires awake tracheal intubation? So after careful examination, I found out that trachea is free and mobile. Mouth opening is adequate, and there are no respiratory distress symptoms due to this thyroid mass. The patient told that these thyroid masses, they are present since his childhood. So we decided to give, and we give successfully spinal with the obturator nerve block for this patient because he was posted for TURBT. After learning airway anesthesia and various tips and tricks to manage difficult airway from the stalwarts who are going to present in this difficult airway workshop, this is a message for particular resident. Don't decide to do awake tracheal intubation in all difficult airway patients. Instead, be smart and choose a smart solution depending on the type of surgery your patient is posted for. So, dear friends, as I said at the start of my presentation, we are visiting the first slide again. I will not repeat what questions we need to answer before giving airway anesthesia for awake tracheal intubation, but I will add to evaluate, monitor, and follow safety protocol. Always oxygenate patient throughout the procedure of awake tracheal intubation. And Balaji sir has already told, always remember the hypoxia kills, hypercarbia does not. Thank you.